evening, folks. Welcome. It's lovely to see you. Some of you are familiar faces. It's great to see you again. While we're just waiting to get started, just again in the chat box, please say where you're from. Send some regards, send some love our way. That would be absolutely wonderful. And also while we're waiting, just to remind everyone to come in on mute and prepare your questions as you're hearing the speakers, because once we finish with the speakers, there'll be an opportunity for you to ask some questions. So just think about that as we go through, but it's really great to see you again. And from my end, I'm just looking through to see where people are from, just to get an idea as to how near or far we are. Now, I spoke to a new person earlier on who sounded as if she was from somewhere pretty far away. Now, I'm trying to remember the name of that individual, because she needs to actually just tell me that she's back in and to say hi. So, that's it. Tabili from South Africa, welcome back. A long way to come, but it's great.
Thank you.
It's great. And we've got Michelle from Seattle. Thank you so much for joining us. Pavlina from London, probably just down the road then, Pavlina. It's wonderful to have you. And Esther, thank you. Esther she says she is the Executive Director of the Amar Institute of Emotional Justice and project founder, an oral history project. That sounds pretty fantastic. I hope we can hear more about that later on. You can put some more information again in the chat later on. Darcy Wilkin is from North London, nearer home. Darcy, depends where home is. So thank you. Just keep coming in and telling us a little bit about yourselves. Elizabeth from Pennsylvania. Welcome, Elizabeth. It's wonderful to have you. And Beverly from London. And Moloko also, it's great to have you with us. It's so good to have an international audience because we have international speakers. And it's so much more fun when we have people from right across the world. We'll get started very shortly, but we'll just wait for a few more of those who have booked to come on, and then we can get started. Greetings from Birmingham. It's lovely, lovely to have you from Birmingham. I could try my Brummie accent, but I have many ways of making a fool of myself, but not that one tonight. Okay? George Matheson. George is one of our faithful listener. It's lovely to have you. And Margaret Andrews, it's great to have you. Margaret's just come in from the waiting room. It's lovely to have you. I see Alfred Officer is a local also, and I've noticed that he has put Jamaica in capital letters. I think that's just trying to draw attention to himself because he's really from London down the road. But it's great to have you nonetheless.
Our diaspora's broad, Marge.
Well, it's quite interesting how it's hanging on to every piece. I'm here, but I'm actually from there, he's saying. But it's wonderful. And if you are going to show off, we've got one of our speakers from Trinidad and Tobago today. So I'm from there, but I'm here today. So we must insist on that.
Yeah, it's great how Zoom and the internet actually can bring us together from across the space.
That is one of the benefits. I've had a number of complaints, personal complaints about Zoom. I'm not quite sure if it's made my life easier or harder, but certainly one of the great things is just how easy it is to connect. And the diaspora can now speak to each other far more easily and a lot cheaper as well. It's a lot more cost effective.
Yeah, welcome Laurent, welcome Guadeloupe, I think that's by the UK as well, and Janice from Essex, I see, welcome.
We've got from Manchester.
Essex, what part of the Caribbean is that?
What part of the Caribbean is Essex? Well, depends. If you're thinking Caribbean, you'll say down the road and round the corner, and when you see that particular house, just ask somebody and they'll correct you. and we'll actually get there. So we'll just let a few more people in, and then we can actually get started. Alison Williams, retired midwife manager, 40 years in the NHS. Alison, you have earned our claps. Welcome.
Indeed, yeah, we salute you. That length of service.
Thank you, thank you.
Okay. I've seen the greetings from Ghana. I've had Terry Lynn from Chicago, Shazaf from Birmingham. So everyone, welcome. It's wonderful to have you. Let's actually get rolling. So it's really just left for me to say a formal good evening or good day, depending on where you are in the world. I guess if you're in Trinidad, it's good afternoon or good something or the other. I'm Marge Loha, and it is my pleasure to welcome you to Black Pack Critical Conversation, a place where we dialogue with leading international thinkers from across the global African diaspora. Now, Black Pack is a collaboration between two organizations, the Transatlantic Roundtable on Religion and Race and Quick Crack Media. We host two online programs, Black Pack Interviews, and that's where our invited guests who are known for particular achievements are asked to delve into their Black Pack and share items of learning and guidance from their personal experience. And Black Pack Critical Conversation, where we invite specialists to share with us and take questions on a particular subject. Now, our critical conversation topic of discussion today is the state of Black health across the African diaspora. And we're welcoming four passionate and inspiring speakers. We've got Dr. Jenny Douglas speaking to us from the UK. Then we've got Dr. Monwabisi Gansho from South Africa. We've got Betty Ann Pilgrim from Trinidad and Tobago. And we've got Dr. Thomas Leviste from the USA. Now, as always, you, our audience, will have an opportunity to put some of your questions to our speakers later in the program. So please, as I said earlier on, just send these via the chat facilities, and then we can put them to our speakers. But for now, I'd like to hand over to our host for this critical conversation, and that's Dr. William Acker. William is a senior lecturer in the Department of Geography at Birkbeck University of London. He's current chair of the Transatlantic Roundtable on Religion and Race. That's an international organization that brings together academics, community activists, and church leaders with the aim of tackling injustices faced by people of African descent around the world. So again, I say welcome to our audience, welcome to William, welcome, a very big welcome to our panel, and it's over to you, William.
Thank you, Marge. I'm really excited about our second critical conversation. Now, our first conversation was on the state of the race globally, and this conversation tonight, I think, is of equal, if not more importance, in the contemporary context, to think about health. I know that COVID has been on everybody's minds, and that in particular parts of the globe, is the disproportionate impact on people of African descent has been felt. We wanted to have a place that within the broader context of the state of health of African descendants across the globe. So in that regards, that's why we brought together this panel to have that critical conversation, to think about the factors impacting our health and what we can do about it. So as Marge outlined, we have four speakers. So two will speak, then there'll be a musical or poetic interlude, then the other two will speak, and then we will have a dialogue, and you'll have the opportunity to ask questions. So without further ado, let me introduce our first two speakers. So our first speaker that we're privileged to have this evening is Dr. Jenny Douglas, who's senior lecturer in health promotion at the Open University. She has over 30 years experience of researching issues around race, gender, and health equity. She's the founder and chair of the Black Women's Health and Wellbeing Research Network. Following her from South Africa, have a doctor, I know him as my friend Monwe Gancho. He's an independent medical practitioner and also an international fellow, a Rooney scholar at Robert Morris University in the US. Gained extensive experience of tackling issues of health as relates to people of African descent, both within the South African context, but then also sharing that learning across the African diaspora. So welcome to you both. Now hand over to Dr. Jenny Douglas.
Hello, thank you very much for inviting me, and thank you everybody for attending. So I'm very much looking forward to the discussions we're going to have this evening or afternoon, depending on where you are. I'm actually speaking from Birmingham, UK. I see that there's somebody else from Birmingham, Shazza. I don't know whether you're from Birmingham, UK or Birmingham, US, but welcome. And also I see there's somebody up. Hi. I see there's somebody from Warwickshire, who I think may be my colleague, Dr. Watson. Okay.
Jenny, nice to see you.
Nice to see you, Naomi. Okay, so I'm going to try really hard now to stick to the 10 minutes, but we'll see how it goes. I'm now going to attempt to share my screen. Okay, can everybody see my screen?
Yes, we can.
Okay, great.
Yes, we can.
Yes, we can. Yes.
Great. Okay, so I know that today we're talking about the state of Black people's health in the UK. I'm going to focus very much on Black women's health. And why am I talking about African and Caribbean women's health? There's been an increase in research on Black and minority ethnic communities in the UK, but often Black women's health, African and Caribbean women's health is often ignored by health researchers and policymakers. And I think sometimes this may be the assumption that we have a large number of African Caribbean women working in the NHS, and therefore they have knowledge about their health and they're in control of their health. But I did a piece of research quite a long time ago now, comparing the experiences of Black women who are nurses and Black women who are not working in the NHS. And I'm afraid they both have the same core experiences. So also, there's been an emphasis on research on Black women and health in the US, and we don't seem to appear to have that tradition here in the UK, where the emphasis has been on education, motherhood, employment, and identity. We do have a number of disparate health research projects which have not received much attention. There is a vast literature on early discrimination of Black nurses in the NHS, and actually I have to say the woman who says she's worked in the NHS for 40 years and is a manager, congratulations, because we have very few Black women in senior management positions in the NHS. And with each reorganisation of the NHS, it's provided an opportunity to displace Black senior managers. I'm just going to run through very quickly some health concerns. African Caribbean people are 5 times more likely than average to have high blood pressure and twice as likely to die of stroke under the age of 65. Also, African Caribbean people are between 3 and 6 times more likely to be diagnosed with schizophrenia. That really relates more to men than to women. I'll come on to that. And the African Caribbean women experience a greater prevalence of hypertension than men, yet men are more likely to receive treatment. And in Higginbotham's study, she actually showed that that an onset of hypertension was often linked to stressful work experiences. And there's a long tradition in African Caribbean communities in Britain of working in public services such as the NHS, social services, and the transport service. And in these areas of employment, the organisations are characterised by low pay and shortage of staff, which leads to a very stressful working environment. And also, this can be compounded by racist attitudes of co-workers and line managers. In relation to Black women and mental health service, we have very little research, but we have more research which is focusing on anxiety and depression in African Caribbean women, which often is not kind of remarked upon. And the stresses of everyday living and living in a racist society often takes its toll on African Caribbean women and can have an overwhelming effect on their psychological well-being. Research in the US by Arlene Geronimus, Arlene talks about weathering, and here she refers to the day-to-day experiences that Black women have in relation to stress and racism, and how this actually can make us 7 years older than our chronological age. In relation to breast cancer, we also know from research that Black women presented on average 21 years younger than white women, and that tumours in young women were considerably more aggressive in Black women, and Black women were twice as likely to die of their disease. The current concerns are around things like organ donation. Black people are 3 times as likely as the general population to develop kidney failure, and yet organ donation rates are still very low. One of the kind of issues that is emerging is in relation to in vitro fertilization. Black women experience lower IVF pregnancy rates than white and Asian women. And the burning issue of today is that Black women are 5 times more likely than white women to die from complications in pregnancy and childbirth. This was in the November 2018 report. The figure has gone down slightly. So Black women are 4.3 times more likely to die from complications in pregnancy and just after childbirth. But that is an alarming statistic, and it's something that we should be doing more about. Now, all of these factors that I have just talked about are actually highlighted by COVID. And COVID has really shone a light on the existing inequalities that exist. So that although Black and minority ethnic communities only make up 14% of the population, 34%, they are 34% of the critically ill COVID sufferers, and are twice as likely to die from COVID than their white counterparts. And Black women are at greater exposure to COVID because they're often frontline workers, nurses, social workers, transport workers. In addition to that, Black women experience workplace bullying, racism and discrimination, and this creates environments that doesn't allow Black women to express and address their concerns about COVID, either in relation to protective equipment, but also in relation to how they feel being on the front line and being exposed. And we've seen the death of a Black woman who worked for London Transport, who was actually spit at. And actually very little has been done about that. She was spit at by somebody who said that they had COVID. We don't know whether they had COVID or not, but nothing has been done to prosecute that person. So once infected, Black women, because of their pre-existing health conditions, this also increases the risk of having a severe infection of COVID. And, they may have underlying conditions such as diabetes and obesity. And also these patterns are socioeconomically, experiences are socially patterned in terms of socioeconomics. So that Black women who are experiencing poverty are more likely to be at risk from COVID. So we can see that for Black women, especially in poorer areas, there's a higher incidence of chronic diseases and multiple long-term conditions, with these conditions occurring at a younger age. And I've already referred to Arlene Geronimus's work on weathering. And of course, this relates to Black women across the life course. Also in relation to pregnancy, in a study last year of pregnant women admitted to UK hospitals, more than half of the pregnant women belong to Asian or Black communities. So, race is not biological. There are no differences between these so-called races. Race is a social construct. But while race is not biological, racism has biological consequences. I just wanted to mention that one of the things that we need to do here in the UK is to have a Black women's health study. And a Black women's health study has been has happened in the US since 1985. And they are following a cohort of 59,000 African American women. And, you know, there's a huge kind of database in terms of publications on Black women's health. And we do not have that here in the UK.
2 minutes, Jenny.
Okay, great. I'm just going to come to the end. So we need a Black women's health study here in the UK because Black women are dying from preventable diseases: high blood pressure, strokes, coronary heart disease, diabetes, maternal mortality. Much of the research on these issues are actually done on white women. Black women, as I said, are aging earlier. Forget about the phrase "black don't crack" because it really does crack. And Black women are really doing the state of Black women's health is of huge concern. And there are many conditions which affect us and which we have little information about. For example, sarcoidosis and lupus. We have set up a Black Women's Health and Wellbeing Research Network, which is a national network to bring together Black women health researchers because often research is quite disparate, and to provide support and knowledge exchange around Black women's health. So to conclude, the health of Black women is inextricably linked to our socioeconomic position, our work experience, our home life, and our experiences of everyday racism. And we need more research. And we need more research on physical, psychological, and emotional well-being. And we need to look at the intersection of race, gender, and class, and the complexity of Black women's lives. And this research needs to be led by Black women. So just to conclude, Mullings and Schultz in 2006 argued that health disparities based on race, racism, class and gender sexism are matters of life and death. And we are certainly seeing that here in the UK, particularly in relation to Black women and maternal mortality. So thank you very much.
Thank you, Jenny. Excellent kickoff. So we hand over straight to Dr. Gancho now.
Thank you very much, William. Thank you so much to the organizers for having me. And I like the approach by the organizers because we seem to be comparing apples with apples here on the diaspora against the global trends on the state of the Black health across the diaspora, the African diaspora in particular. In answering really the question, why is COVID-19 deadlier in the diaspora than in the Western countries, a couple of few points from the South African point of view is that South Africa is, in fact, in Africa, where Africans are in vast majority, unlike most probably other Africans in the diaspora. Therefore, in all the statistics, data, achievements, if there are any achievements, and I can cite things like the surveillance and the discovery of the variant, we call it in South Africa variant 501YV2, which is part of the research that has been done. And the challenges are really in our totality as contribution to the other diaspora community challenges. What that means is what we have as the Black diaspora in Africa, in South Africa, becomes difficult to say this is only for whites or in any other way, but I can talk to that later. As South Africa, we really find ourselves in the forefront for all the good and the bad reasons, actually. I must mention, therefore, upfront that even in this conversation, Africa is a reference point. With more homogeneity in terms of the term itself, Black, or more contemporary people call it people of color, because here we are in majority, unlike some countries, as I have mentioned. There is a historical political context to such reference, and we can discuss that later. There is, however, an important aspect, which is the divergence of fatalities that has scientists puzzled in the rest of the continent in general, and the sub-Saharan Africa in particular. It is relevant for the diaspora to note that in the wake of the latest surveillance results that we have, it shows a worrying trend that of highly transmittable COVID-19. I've mentioned one of the variants that has been found near first identified in one part of South Africa called the Eastern Cape. Interestingly enough, even the name, it is in the Nelson Mandela Bay. You can check up in the map, and I think I have the map of the world just behind me. It moved to the other parts of the country, and it became a very dominant variant for a period of time, and that gave us, as a country in South Africa, even a bad outlook in the world, because now we've discovered it, we have announced it through our competence of our researchers, and we get punished for it because travel restrictions are imposed on us, and it would appear like some of the countries that have not researched or have not advertised or rather reported on it are getting the better end of the stick. Anyway, in the continent of Africa, and from the South African point of view, where I'm currently based, we are presented with unique set of colonial circumstances, ranging from colonialism itself and the apartheid as it evolved to be, we then had to deal with a devastating blow of economic growth, which manifested itself in healthcare. It was never really the intention, as you can imagine, of both systems, that is colonialism and apartheid. It was never their intention to benefit the indigenous people, who were and still are in majority. Complicating these two was the deliberate intention of the evildoers in the evident legacy that is currently ravaging the continent from the political, economic development, and is expressing itself in the state of health across the African continent. We have not made this any better as the diaspora in this part of the world, because we have mismanagement of resources now. We have got blatant corruption in many regions and even countries that can be rampant and be seen in procurement of services and poor maintenance of infrastructure, and those are not helpful and are inexcusable. What we have seen during these pandemics, and we had two in particular that I would like to mention, HIV and AIDS, COVID-19 now, excuse me, they lay bare the exposure, they expose the deep fault lines in the health system. These corruptions that we find in procurement of the personal protection equipments and vaccines now are coming up, and we've seen, and we have what you call the vaccine nationalism. Those are not helping. We can also deal and discuss that later. Of course, some progressive countries are addressing these drawbacks using democratic institutions, holding leaders and officials accountable. In South Africa, we have what is called by the governing politicians power of embarrassment to put decision makers in action. That is when you see when you use the highest office or the parliament as a platform to expose the inaction of decision makers, seems to be working. And I think that if we can make more use of that in decision making, we can go some way. The danger that Africa and the diaspora is facing, and I'm using the two terms interchangeably here, is the vulnerability to the dumping and being used as the guinea pigs in the experimentation on the continent. And we have to be careful about this. In South Africa, the Department of Department of Science and Technology, together with the Department of Health, have identified the importance of what is called genomic surveillance as, in fact, a discipline in its own right. That needs to be researched in Africa itself, since the continent is hailed as having the most genetically diverse humanity in the world. Now, we all know this. Thus, establishing of a center in a province called KwaZulu-Natal Research, Innovation and Sequencing Platform. And the network for genomic surveillance in South Africa has been established to complete the sequencing of the COVID-19 genomes. In the case of South Africa, ladies and gentlemen, which is a home to almost 60 million people, we have seen over 54,000 deaths from COVID-19. The macro level disparities remain and evident and are emblematic in terms of how they express themselves. In the continent, the studies on public data have shown on analysis that geopolitical and immigration activities have huge impact on the state health of a nation, including gender and age-related fatality ratios amongst morbidities and mortalities, that is the deaths and illnesses due to the related complications. We've seen this being done in some countries around us, Malawi, mainly rural, and some of the rural parts of South Africa. People of color in the continent, Black people in particular, are still affected mainly by activities that are taking place public level, social, cultural practices, political events, and political activities that are not helpful in terms of the efficient and cost-effective health delivery. Furthermore, in the country, in South Africa, every 1 million people, 1,800 have died from COVID as we speak. This needs to be better understood and really be decoded to contain this global outbreak, as well as avoid future public health crises that we will have. However, it's not all doom. We have to take into consideration, though, different hypotheses that point to some form of protection against the COVID-19 in the diaspora. And this is strictly a hypothesis for now, that because of our populations that are continuously exposed to many kinds of pathogens by virtue of poverty and these social circumstances, including the viruses and the immune system, it does not hyper-react, as it were, to any new variation that comes in. That is some form of protection, a natural protection, which people and many experts are looking at now. Many experts acknowledge the genetics or cross-immunity, as it is called. It could be at play here in protecting our people, even in dire circumstances that they find themselves. And work has been done about this both in South Africa, India and Bangladesh and Pakistan mainly, so we have to watch that space. I think as I conclude this, I have to mention that even though over 3 million people have died from COVID-19 worldwide, and most affected are reportedly, obviously, in US, Brazil, Mexico, and India, which has now started to have what is called a double mutant. What is important is that in the face of adverse geopolitical economics, of vaccine nationalism, each country in the diaspora or with the diaspora needs to greatly increase their vaccination coverage and work harder to implement other public health measures to contain this pandemic. COVID-19 in South Africa works, the initiatives that we have, we work with World Health Organization, CDC, Africa Center for Diseases, etc. And we have real-time monitoring of what is happening both in the country and elsewhere. Now, not all the data is available at this stage, even on the vaccines. Up to phase 3 trials will need to be done, and that takes about 4 years to be concluded. So I think that maybe I can just say before I hand over to you, Chair, is that as we promote vaccines and COVID-19 vaccine candidates that have proven their resilience and their intention to be of use, we must encourage this in the diaspora. If the trends are evidential in the diaspora, even in this forum, which we are participating in now, we have to find a way of forcing the scientists, virologists to offer theories and solutions as to why COVID-19 is cutting a more deadly blow in the North-South divide. Finally, the diaspora, in my opinion, has to participate in a platform and a network for genomic surveillance to influence and contribute, leveraging on our largest genomic diversity that we now already know. Now we must make use of these pathogens, genomics, that we have identified amongst ourselves in the diaspora for monitoring of transmission, of the dynamics of the infectious agents, and produce potential vaccines ourselves. Thanks, Willie.
Thank you.
Thank you, Dr. Gancho. I'm sure we'll definitely come back to some of those things you've raised in the questions. So people, please get your questions ready and put them in the chat. Over to you now, Marge.
Mervyn.
So in actual fact, I'm handing over to Mervyn.
Yes, good evening, everyone. What we didn't know when we were planning this event this evening, we didn't know where we would be in terms of COVID-19 pandemic. We had no idea where we would be in terms of Britain's response, and no one could have predicted what would be happening in India right now. Also, we didn't know that just this week we'd have got the results of the Derek Chauvin trial. And what we've been interested in during this period of lockdown is the intersection, the overlap between a race hate pandemic and the COVID-19 pandemic. This is something that's alluded to in the book that I've written, I Can't Breathe. Some of you will know about it. And we're going to share a section from that, which includes the overlap of these two phenomena happening at this time, which is going to be read by Jean Michello.
Thank you, Mervyn.
So
8 minutes, 46 seconds of shame. The American dream, now a nightmare exposed in broad daylight. Brazen disregard for the sanctity of life. A very public lynching. Strange fruit, Floyd. Life hanging by a thread. Cop with cold contempt for the noble institution of law and order that trusted him to be judge and jury and executioner too. No need to call CSI. This crime scene has been seen on every screen all over the world. This was the hardest of the diehards to watch. I Can't Breathe. A toxic virus engulfs the globe, and no vaccine can save us from its vicious grip. Some say it's a new strain that has already claimed millions of lives throughout history. Those most likely to die all have an underlying chronic disease. It's called melanin. High doses will leave you particularly vulnerable. Black on black, we reject. But blue on black, as we all have read, leaves the brothers dead, unable to breathe. The results have been devastating on a global scale. people are dying on the streets of this race hate pandemic. I can't breathe. Not the cry of a single voice, but the chorus of a world in shock. The refrain of a people of a particular hue. I can't breathe, said George Floyd, said Eric Garner, said Tamir Rice, said Ahmaud Arbery, said Breonna Taylor. How many more memorial walls will we need to build to etch the names of all our fallen heroes?
Thank you, Jean.
Wow, that was very powerful, Jean. Thank you for that. So now move to our third and fourth speakers after our excellent introductions. So our third speaker is Betty Ann Pilgrim. She's the Chief Nursing Officer for Trinidad and Tobago. She's also the instigator and lead of the Eastern Caribbean Embracing Leadership Program. And then our fourth speaker is Dr. Thomas Levaste. He's the Dean and Weatherhead Presidential Chair of Health Equity at Tulane University in New Orleans. Has extensive research experience on various aspects of public health. So let me hand over now to Betty Ann.
Good evening, everyone. Good evening. It's wonderful to be here. I'm greeting you from the beautiful island of Trinidad and Tobago. As you can see, I don't live too far from the sea, so you can enjoy the sight at the back. Right, so I'm going to talk about, we're looking at health in Trinidad and Tobago. What I've done is I would like to give you a background so you can understand what healthcare is like in Trinidad and Tobago. Let's see, so let's start. So some fast facts about Trinidad and Tobago. For those of you who don't know, we are a Trin Island Republic, Trinidad and Tobago. And Trinidad and Tobago are the southernmost territory in the West Indies. We are located very close to Venezuela, and we have a population of almost 1.4 million. And it's multi-ethnic with two major groups, Indo-Trinidadian and Afro-Trinidadian. And we have a tropical climate. Now, the structure of healthcare in Trinidad and Tobago is like this. We have the Ministry of Health, who is responsible for the oversight of the entire health system. And it plays a central role in protection of the population's health and ensuring that all organizations and institutions that produce health goods and services conform to the standards of safety. They are the policy-making body as well for health. In 1994, healthcare was divulged from Ministry of Health to the Regional Health Authority. The Regional Health Authorities now provide healthcare services in Trinidad and Tobago. And we have 5, 1 in Tobago and 4 in Trinidad. This system is a two-tier system where we have the public system, which includes where we have the RHAs, or the Regional Health Authorities. The public system is made up of hospitals. We have district health facilities, and the district health facilities were developed in order to relieve the hospitals from the burden of admissions. So persons are seen in the district health facilities, and then only if they need to be admitted, they are then forwarded to the hospitals. And then we have several health centers. within each regional health authority. This service is free. And we also have private, lots of private hospitals have cropped up over the years in Trinidad and Tobago, and we also have services provided by private doctors in the offices and many private clinics. The health profile in Trinidad and Tobago, and I must say here, it's basically the same for the Eastern Caribbean. We have a lot of challenges in this part of the Caribbean. Heart disease being the highest ranking cause of death in Trinidad and Tobago, and accounting for over 25% of the deaths annually. We also have a high prevalence of diabetes mellitus, which leads to many other complications, which I didn't mention here, but like renal disease and also hypertension. This accounts for about 12% of deaths in Trinidad and Tobago, and also cancer, which is growing. I couldn't get the statistics for today, however, but it is growing. But with the highest, in men, it's prostate cancer, and in female, cancer of the ovaries and the cervix and the, cancer and breast. Life expectancy in Trinidad and Tobago, the average overall is 68.9 age, and men 70 years, 0.3, and female 72.8. This has increased, and it is increasing, and we now have quite a number. We have a growing elderly population and many centurions. The health profile continued: 4 main diseases: cardiovascular, cancer, chronic respiratory diseases like COPD or chronic obstructive pulmonary disease, and asthma and diabetes. I like this definition, that's why I'm going to use it. If you're looking at health inequalities are unfair and avoidable differences in health across the population and between different groups within the society. Health inequalities arise because of conditions in which we are born, grow, live, work, and age. These conditions influence our opportunities for good health and how we think, feel, and act. And this shapes our mental health, physical health, and well-being. And I love this definition because when I looked at what is happening with health in Trinidad and Tobago, it really encapsulates what exactly is happening. Now, health inequalities matter because, as we all know, health is our wealth. Health is foundational. It's the basis for all activities. If we are healthy, then we are happier. So health inequality, basis for health for all activities. So health inequality is more important to people than any other. Our health is our wealth. Ill health is a source of poverty, low productivity, poor education. Child ill health can worsen lifetime opportunities. And you will see how that relates later on when I talk about some of the things in Trinidad and Tobago. The higher health inequality, the worse the health of the nation. And inequality matters especially for the poor. Health inequalities are also a reflection of other inequalities. Now, in Trinidad and Tobago, these are just a few that I've picked out. And these are interrelated. And what do I mean? Well, first of all, our lifestyle choices are what determines whether our health is good or bad. And that is a challenge we have in our country with lifestyle choices and with the change in our culture. We see people are making much more poor choices than we did many years ago, which I would highlight when I come to another slide and talking about food choices and so on. Now, education. In Trinidad and Tobago, we have an excellent education system, and education is free from primary to tertiary. It's only recently, because of economic challenges, there have been changes with the tertiary provision of tertiary education, but it is still free. Not all of it, but some of it. And over 97% of persons in Trinidad and Tobago finish a primary education. and then about 79% finish primary. And out of that, the majority are females who finish. And then as we go into the tertiary education, the span widens with more women being in employment. Now, as I said, many of these are interrelated. So persons who are high income and have good wealth get good employment, then they're able to provide proper housing. And we have challenges among the poorer groups where housing is very poor, where squatting is an issue, and with that you do not have pipe-borne water, electricity, and etc. But because of time, I'm just rushing through here. Now, the ethnic profile, as I mentioned before, are mainly Afro-Trinidadian and few Chinese, Hispanics, whites or Caucasian, and we have a lot of persons from Venezuela and Cuba. In Trinidad and Tobago, we have some diseases that are particularly relevant per racial group, like sickle cell, thalassemia, mainly among the Afro-Trinidadians, and thalassemia Indo, and fibroids more among the Afro, but it affects everybody, and diabetes more the Asian population. And we are seeing issues with alcoholism and drugs among both races. It's increasing. Now, and so I've just broken it down here. Afro-Caribbean, we have more mental health issues, homelessness, death by violent crime, especially shooting, obesity is on the rise, hypertension and diabetes, alcohol consumption is also rising, even starting from as early as school ages, where a survey was done and they said about 1 in 10 of the between 10 and 15-year-olds had already had cigarettes. And also we see a lack of exercise. Trinidadian, more diabetes, mainly because of their practice with high carbohydrate diet. Cardiac illness is also very high, twice as much in the Indo-Caribbean, Indo-Trinidadian than in the African, and also alcohol consumption and tobacco smoking, lack of exercise and obesity, as mentioned before. Now, in our country, there are several programs that have been initiated by the government in order to mitigate against health inequalities and the problems that mentioned before. We have a national strategic plan for prevention of NCDs, and that is an excellent plan, and you can have a read, it's online. Also, we have developed many policies, programs, and strategies to respond to the NCD challenge. There are intersectoral and multi-sectoral action between government agencies and public sector, whole government action, and etc. So let's move on. So I use an acronym that many of us know in order to talk about some of the issues. What is important here is that the choices carry consequences. And because of nutritional choices that people make, we have seen in Trinidad and Tobago an increase in lifestyle diseases because people do not cook as before. Many years ago, we were known for a culture that didn't eat out much, but we see more of that, and people are making poor choices, eating unhealthy foods like doubles and KFC. Also exercise, people are very inactive, especially now that we are more tech savvy. You have children on their devices more, and also and that leads to obesity and so on. Now, I just want to say that this inactivity has also increased due to COVID and the lockdown. Yes, and okay, I wouldn't say any more there. Something else I was going to say. I got a little. So water. In Trinidad and Tobago, we have had increased access to water supply, but it's also unreliable in some areas. We have over 95% of the country has water, have access to clean water and so on and so on. But in terms of health choices, people still choose to drink more sugary drinks than water, and we have seen a plethora of problems related to that, kidney related issues and so on. Even though we are tropical, we still have a high level of persons with vitamin D issues, and we have issues with not growing we try to inform people to stay out of the sun during the 12 o'clock hour, and, you know, when it's hottest and so on. But in terms of that, people stay out of the sun, and we therefore have an issue with the low vitamin D. Temperance, well, overeating, binge drinking, smoking, lots of poor lifestyle choices are what is affecting the health of our nation. Last one, again, pollution. We have a challenge here with the Saharan dust and sometimes poor air quality because of the industrialization, but not generally, we don't have a big problem with air pollution. Rest. Now, we have a party culture. In spite of the lockdown, we still have had some challenges, and I didn't talk much about COVID, but recently we've had more lockdown because the cases went up after Easter. But we have an issue with persons not resting. And also we have a lot of religions, and religion plays a major role in TNT. We have predominantly Christian, and then Muslim and the Hindu. Now, in the question and answer section, I would seek to answer, your questions to some of the issues that I've raised here. Thank you.
Thank you, Betty Ann. Yeah, I'm sure we'll certainly come back to those. So over to you, Dr. LeVace now.
Okay, thank you. Thank you very much. I'm going to share my screen. If you just give me 1 second. First, let me thank the organizers for inviting me to participate in this important meeting. I think that we need to have more dialogues across the diaspora like this one, and I welcome this opportunity to address this international audience today about the, just 1 second, and I'll, about the health status of the African American community. So I like to use this chart as an illustration of the overall health status in the United States across different racial and ethnic groups. And this, I think, summarizes quite nicely the pattern. And I think you'll see this same pattern across many different health outcomes, not unlike the data that you saw for the UK and for South Africa and Trinidad, where African Americans have the highest mortality rate than of all racial and ethnic groups in the United States. This pattern has been consistent. I'm showing this chart here for 2019, but this chart could have been for 1999, it could have been 1989, 79, 59, 49. It's the same pattern. African Americans live sicker and die younger than all racial and ethnic groups in the United States. So the question is why? When you ask that question, several explanations you often come to people's minds. These explanations, however, I would say are myths. They are not the reason why we have these racial disparities in the United States. It is not the case that the disparities exist fundamentally because of access to healthcare, although we do have racial disparities in access to healthcare in the United States. They do not exist because of biological or genetic differences between race groups. It is easy, I think, to look at people and see differences in their skin color and assume that what we see in their skin color is telling us. I'd like to ask if everyone could please mute themselves. That we can look at people's skin color and assume that what we see on the outside of the skin tells us something important about what's happening under the skin. But there's no scientific evidence to support the idea that there are biological or genetic differences between race groups. The third explanation is that it's really not race, it's really social position or socioeconomic status or social class or poverty, another widely held myth that is also not true, a myth that we fight with a lot in the United States, especially in addition to other populations, more affluent African Americans often believe that it's really about social class and not about race, or fundamentally not really race, but actually racism is what race is measuring. So let me just quickly comment about each of these myths before I talk about what is happening in the US. So first, this chart is from a study that I conducted some years ago in the United States, in Baltimore. This was from 3 hospitals in Baltimore. We abstracted 10,000 medical records from these 3 hospitals, and using the criteria from the American College of Cardiology, we reviewed the charts to determine which patients were appropriate candidates to be referred for coronary angiography. Now, coronary angiography is a procedure that is used to diagnose heart disease. It is a diagnostic procedure, but it is the first step towards someone potentially being referred for heart bypass surgery or other forms of revascularization. On this chart, these are all patients that have health insurance, that did have the ability to pay for the care that they would have received, and they were all being seen at a hospital that had the ability to provide the service. Based on the chart review that we conducted, 100% of the patients represented on this chart should have been referred for the procedure, meaning all of the white patients and all of the black patients should have been referred. But we see 2 things here. We see first that among the white patients, only about 82% were referred. So we've got a quality of care problem in the United States, because even here, not all of the white patients that should have been referred were referred. But when you get beyond the quality problem, we have a racial disparity in quality problem, because less than 60% of the black patients were referred. So here's a case where we had complete access to healthcare. Whatever barriers these patients had to overcome to get seen, they overcame those barriers. They got seen, they got a diagnosis, and the diagnosis indicated that they should have been referred, but they were not, because access to healthcare alone will not resolve the health disparities problem. The second explanation is that there's biological differences. And in 2005, we had in the United States the first drug ever approved for use in only one race group. This is a drug called Bidil, and Bidil was approved in the United States to treat congestive heart failure. Based on a study that was conducted that showed that all patients of all racial and ethnic backgrounds benefited, but it showed that a higher percentage of the patients that benefited were African American. And on this fallacious reading of the data, there was the conclusion that this should be approved for use in only black patients. But when you think about that for a moment, what is race, and in what way is race a biological concept when race is determined purely by political, cultural, and social phenomena? For example, Colin Powell, who is the former Surgeon General of the United States, has 2 grandparents from the UK, 2 grandparents from Jamaica, and he's born in the United States. And we call him an African American. Former President Obama has 2 grandparents from Kenya. He has 2 white American grandparents, and he's born in the United States. And we call him African American. Golfer Tiger Woods has 1 grandparent from China, 1 grandparent from Thailand, 2 grandparents from the United States, 1 who is black and 1 who is white, and both of whom have Native American or indigenous ancestry. And we call him African American. So these 3 men who have ancestries from far-flung continents of the world, who have very different heritage, very different ancestry, we consider all of these men to be African American because the commonality among them is the fact that they have darker skin as a result of higher concentration of melanin in their bodies. Race is measuring melanin content, and melanin content is the marker that is used to determine who is exposed to racist behavior, and as a result, we get the race disparities. But when we focus on biological explanations as opposed to the cultural explanations, which are really driving the disparities, then we're focusing on the wrong solution, and therefore we will not make progress in addressing the race disparities problem. By the way, he looks like a black guy to me if simply visualizing a person and determining their race based on their skin color tells us something about their genetic characteristics. However, This is not an African American. This is Vijay Singh, professional golfer Vijay Singh, who is from Fiji. So this illusion that race is biology can lead us astray, and as a result, reify the racial disparities by leading people to the conclusion that the disparities are immutable, determined by the genetic lottery, as opposed to mutable because they're determined by decisions made by humans. The last myth is that it's really not race, it's really social position, and this is the easiest one. It's the easiest myth to fall into, but it's the easiest one to dispel. If I simply show you some charts looking at a variety of health outcomes, it doesn't matter much what health outcome it is. If you look at different levels of social position, we see racial disparities at all levels. Getting an education, having a high income does not spare you from racism and does not spare you from racial disparities, as these charts show. So if it's not genetics, if it's not access to healthcare, if it's not socioeconomic status, then what is it? I would say that what is the real driver is the fact that while we all live in the United States together, we experience the country very differently, because the country is dramatically racially segregated, and racial segregation, the fact that we don't live near each other, creates an infrastructure that produces the disparities. It creates that infrastructure because when you look at the communities that have access to the resources necessary to live healthy lifestyles and communities that do not have access to those resources, when you look at which communities are exposed to higher rates of health risks, such as environmental health hazards, target marketing for tobacco and alcohol and other unhealthy products, and who are the groups that are not exposed to those health risks. These track by community, geography, and as a result by race. And therefore, the fact that we live in segregated communities facilitates this targeting. Here's what I mean. This is a map of the United States that was produced based on the 2010 census, the enumeration of the US population. This map was produced, the producers of this map placed a dot on the map representing every American. So over 300 million dots on this map, and the dots are color-coded. The blue dots represent white Americans, the green dots represent Black Americans, Asians are represented by the red dots, and Hispanics by the orange dots. Let me hone in on one city. This is Washington, D.C., the nation's capital. If you look at Washington, D.C., in this relatively small geographic area, you see that the green dots representing African Americans clearly are to the east of the city. The blue dots are clearly to the west of the city. If we look at other cities, a study that was done by the Robert Wood Johnson Foundation took this same principle and overlaid the Washington, D.C. metro system. And they make the point that when you're going home from work and you're at the Metro Center stop, which I used to do when I worked in Washington, depending upon which train line you went on, you were catching to go home, you can predict the life expectancy of the person. So if you get on the green line and go to the east of the city, to Prince George's County, which is a predominantly Black community, life expectancy is 75 years. If you're getting on the red line to go to the west, northwest, into Montgomery County, which is predominantly white, life expectancy of 83. If you get on the orange or the blue line going into the western side of the city, into Fairfax County, Virginia, life expectancy is about 80. So in this 12-mile radius, you have up to a 9-year difference in life expectancy. This is not genetic. This is not socioeconomic status. This is different health risk environments that people live in, and that tracks in the United States with race. Here's another city. This is New Orleans, the city that I currently live in. We see a clear pattern where the green dots representing African Americans are to the east of the city. The blue dots representing white Americans are to the west of the city. Here's another city. This is New York, the city that I was born in and spent most of my childhood. Again, we see New York City as a rainbow, where there's clear demarcations, where the communities where the green dots live, meaning the Black Americans live, communities where the blue dots live, meaning white Americans, and where the orange and red dots are, meaning Asian and Hispanic. We conducted a study, my team and I conducted a study where we went into a racially integrated community that we were able to identify, and we replicated the protocol that is used by the US government to collect the National Health Interview Survey. And we wanted to know, do you find the same racial disparities in an integrated environment where people are living under similar conditions that you find when you do the national studies? And what we found for each of these outcomes, and we've now done this for a large number of outcomes, when you do this analysis, we find that when you take the national statistics and do the analysis at the national level, you find 61% greater odds for African Americans being diabetic. In the community where Blacks and whites are living together under the same conditions, we find no race difference in diabetes. For obesity among women, 87% greater odds for African American women to be obese nationally. But when we find Black and white people living in the same environment, and in the case of this study, this was a low-income, very challenged environment, we find very high rates of obesity for everyone of all race groups. So we find no race difference in obesity. For hypertension, nationally, we find that African Americans have about 100% greater odds of being hypertensive, meaning they're about double the likelihood of being, double the odds of being hypertensive compared to whites. But in the community that we studied that was racially integrated, we find only a 42% higher odds of hypertension. So as we are still in the midst of a pandemic, I did want to just make a couple of points about the pandemic and how this all overlays with the pandemic. In the US, the most recent data that I was able to gain access to shows that African Americans are about 1.4 times more likely than white Americans to have died from COVID-19 in the United States. The explanations for this go along the same pattern that I spoke about earlier. Earlier explanations was that the disparities that we're finding in COVID mortality was the result of higher rates of underlying chronic conditions among African Americans. This idea I roundly rejected, and we later came to find out that it was not underlying chronic conditions that was driving the disparities. It was not health behavior by itself that was driving the disparities, because health behavior is a function of access. If you live in a community where you do not have access to healthy foods, then your choices are limited, and as a result, it is not a function of your choices that determines what you're eating or smoking and drinking. It's a function of what's available to you and what you're being exposed to. In fact, the chronic conditions argument never made any sense to me, because here in the southern part of the United States where I live now, the rates of these chronic conditions are extremely high among white Americans. And in fact, white Americans in the South, in many cases, have worse health status than Black Americans living in the North. But when we looked at the structural determinants, such as segregation, such as differences in the occupations that Black Americans work in, this is where we found the explanation for why African Americans have a higher rate of COVID-19 infection and a higher rate of mortality. That is that African Americans are more likely to live, to work in occupations that place them at risk. Who has a job that allows them to work from home on Zoom all day and still collect their full salary? Is that privilege distributed evenly among all race groups in the United States? I can tell you it is not. And it was African Americans who worked the jobs that made it possible for people to work at home on Zoom and still collect their full check. This is why African Americans had higher rate of COVID, especially early in the pandemic. And then the fact that they live in segregated communities means that when you go home after work, you are more likely to take the virus back to your community, which is disproportionately going to be Black, and more Blacks are going to be, therefore, exposed to the virus. It was segregation and the fact that we live in have very different experiences living in this country is what is driving the disparities, not only in COVID, but the disparities in other health outcomes as well. So I'll stop there, and I look forward to any questions you have and engaging in a dialogue about what's happening in the U.S. As well as the African diaspora.
Thank you, Dr. LeVay. Thank you to all our panelists for a really insightful and informative presentations. You did say we were going to have another musical interlude, but I think because of the time, we're only going to deal with the questions, and we'll save the musical interlude for another time. So, our technical people, if you can bring all the people back together into the spotlight so you can see everybody, then I'll kick off with a couple of questions. I think my first question I want to address is to Jenny and to Betty Ann, because you're both talking predominantly about African Caribbeans, one in a UK context, one in a Trinidad and Tobago context. So I'm wondering, it seems like there seem to be similar health outcomes in some respects. But I wanted to ask you, I suppose, what then do you think then is the role of public health policy in trying to bring about different health outcomes for this group? In a country like Trinidad and Tobago, Betty Ann, where you said it was the government is there, I suppose it's a Black and brown government operating healthcare policies. Would we expect to see better health outcomes than we would to see for that Afro-Caribbean population in the UK, for example? And Jenny, what do you think about that in relation to UK healthcare policy compared to maybe Caribbean?
Okay, do you want me to
yeah, if you go with that one.
I think that we have a long way to go in the UK to actually recognise the impact of racism. And, I found Thomas's presentation very interesting. I think here in the UK, and we recently had the SOAR report, which, tried to, although they've kind of backed down a bit now, but initially tried to say that, institutional racism wasn't an issue. But I think that here in the UK, we need more research which actually looks at institutional racism being one of the social determinants of health. And I think until we can start to build that into public health policy, we will continue to see inequity in health. And, that is particularly true in terms of Black women and maternal mortality. Although we have very small numbers and it's very difficult to do some analysis on those numbers, though the inequality in terms of maternal mortality is not due to social class. It is not due to pre-existing conditions. So what is it due to? Is it due to the racism that Black women experience when they go into hospital to give birth?
Betty, did you want to come in? And I suppose you didn't specifically talk about maternal mortality in Trinidad and Tobago. Is that a different picture?
Right. Well, I'm happy to report that maternal mortality has gone down. And with regards to the Sustainable Development Goals and so on, we were supposed to reduce that I can't remember the number. I didn't really get that, but we reduced it over 10 years before. So we were looking at by 2030, but since last year, we reduced maternal and child mortality because of the measures taken, policy measures by the Ministry of Health. We hired a director of women's health, and several policy documents were produced to address the issues that were taking place in Trinidad and Tobago to reduce maternal and child mortality and morbidity. So it has gone down. In Trinidad and Tobago, the issue is not so much race that drives the disparities. What happens is, as I mentioned, education and also lifestyle choices. So those who are more educated make better choices, they live in better places, so therefore their health is better. Yes? So therefore the policies that comes from the Ministry of Health is to address the issues mainly in those poor areas, even though it's across the board for Trinidad and Tobago. And the way the healthcare is structured, I mentioned the regional health authorities. Now, within a regional health authority, you have also, I mentioned the hospitals, the district health facilities, and the clinics. The clinics are in the community, and therefore they meet the needs of the health needs of the persons in the community. Yeah?
Yeah. Thank you. Let me now ask a question to Monway and to Thomas. There's South Africa and the US, you've got apartheid, you've got Jim Crow segregation. To what extent are they then, the health disparities we're seeing, are they legacies of those? Or to what degree then are these contemporary manifestations? So in a way, I'm going to ask us this is, are these things ever going to end? Do historical disparities, contemporary manifestations, do they mean that there's always going to be a disproportionate healthcare impact for African descendants in those contexts as a result of those historical structural inequalities?
Maybe let me start, William. Well, since the advent of our democracy in 1994, a lot of things needed to be reversed. And in us reversing the laws of apartheid and its policies in recent times, and I'm saying in recent times because prior to that, it was the colonial era that we had, which was a colonialism of special type, because for a long time, since the beginning of the 1900s, we had colonialism that was taking place inside the country, where the UK or the Great Britain had kind of withdrew from South Africa, and the Boer republics, Afrikaners, so to speak, came in and perpetuated the same principles of colonialism. Why I'm mentioning that is because a series of institutionalized racism took place in South Africa, which by 1994, a lot of reversal of all of those things needed to be done. Now, some critics tended to call that apartheid in reverse, and many of us were preferred to call it reversal of apartheid, if you get what I mean. Now, with all of these, in reversal of the policies, the impact on healthcare and the legacy became a major project that meant to bring people back to normality, bring the policies to normality, bring the socio-economic stratification of the population back to normality, and there's no other way of dealing with that other than the segregation that took place over 300 years of our institutionalized racism needed to be actively addressed. We're still only about 28 years into that process. Whether we will come up and at some stage come to equalize and come up with this equalizer, it's a matter of time, and it depends on the vigor, the political will of the governing party and the government of the day to deal with this. You cannot have a situation where you have people segregated in terms of residence, in terms of access to education, in terms of access to participation in economy, and which is clearly demarcated without trampling on some people's toes, where people feel that what they have been, and I'm referring mainly to the people of Caucasian background here, without them feeling that what they have been having all these years is something that they have become so accustomed to, felt even a sense of entitlement to a point where when you take it away, you are now, in order to redress the imbalances of the past, you are like discriminating against them. Now you have to, we had to, as a country, and we continue to do this, to make sure that the access to the resources and to the capital that will enable people to live a much better socio-economic that is equivalent to the rest of the world. Now, we've got a country in South Africa where the two worlds, the first world and the second world, live side by side to each other, with glaring disparities, glaring differences that you might think at some stage you are in a mini New York or mini London of this country, or on the other side of the same neighborhood, you are like in Haiti, and I'm not mentioning Haiti in any disrespectful way, but that is a reality in which we find ourselves. So to answer your question, whether at some stage these legacies will ever be reversed or not, my answer to that is yes, they will be addressed. We'll come to a situation where the wealth of our nation and the wealth of our country is shared amongst its people, and we just have to be determined and do it expeditiously, and we must do it efficiently in order for it to be effective in a manner that is not destroying the infrastructure, the resources that we have, and the human capital that we are nurturing. It's still early days.
Thank you. Thomas?
Well, it's very interesting to hear the South African experience. The U.S. experience is quite different. You know, after emancipation, we had an 11-year period called Reconstruction, where the U.S. government made attempts to begin to make redress from slavery. That lasted only 11 years, and then we went into another period of repression that may, in some ways, could be argued to be as bad as slavery, which was Jim Crow, where you didn't even have the protection of being property, and therefore the property owner not wanting you to be harmed by others. Can even make the argument there. So to answer your question, I think that the disparities in health that we see today are fundamentally the result of historical and contemporary factors. So is the historical factors are important in that this was the creation of a system of governance, a system of how to organize a society, and that society's organization was not organized to benefit Black people. It was organized in order to be able to benefit from the labor of Black people. So that's the historical chain that we still live with today in the United States. Contemporarily, we now have a society, a culture, where the differential treatment of people on the basis of race is more acceptable, or has been more acceptable, although there may be some the beginnings of some changes in the culture here. So I do think that we can redress our 401 years of racism, of basically a 400-year-long genocidal attempt that has been perpetrated against Black Americans. I do think we can redress it, but it's only going to happen when there's a concerted effort to restructure society in ways that do not differentially benefit people on the basis of race. So intergenerational transfer of wealth, If your grandparents and great-grandparents did not have the ability to own land, then you'd have no chance of inheriting land, right? And so this wealth continues to transfer from one generation to the next. So unless there is some sort of an intervention that happens, we won't be able to make up and catch up from that historical legacy.
Thank you. There's a few questions in the chat there, but I want to respect people's time. We said we finish at 9, so please just give us 5 minutes. So what I will ask, I'll try and encapsulate some of these questions together, which seem to be suggesting, in a sense, what is the role of Black communities in terms of how do we see the way forward in relation to our own healthcare? After you listen to each other, are there ways of networking? Are there things going on in Black communities that can point to our empowerment in relation to these health issues? In a sense, what message would you want to give to our wider audience in terms of us being able to kind of empower us to challenge systems of injustice and also to kind of take better care of and control of our health situations? So maybe let's go in the order that people spoke. So Jenny, can you go take that one first?
Sorry, can I not take it first? Because I was just trying to reply to somebody's question in the chat box. So can somebody else take the question? I'll take it next.
Does anybody want to take it? First, Monwa, you were the second speaker, so do you want to?
Okay, thank you. I think what is it that needs to be done by the diaspora and the continent, and I'm speaking from the continent point of view, the motherland, is that we must take our destiny into our hands. We need to make decisions that at government level, at policy making level, we have got a clear chart of where we want to go. Politically, politics alone are not going to bring food on the table. Economy is, and a thriving economy, is the economy that will have spin-offs in healthcare, which will have these not only access to healthcare, but quality healthcare that we need. Those decisions need to be made at the highest level of decision making. I mentioned in my presentation what is called the power of embarrassment of the officials into action, which basically means that decision makers have to do what they have to do, and what they are meant to do is to make decisions that will enable any particular community system into action. No more talk to a point where we do not see the results of what needs to be done. So we also need to leverage on the strengths that we have as the diaspora. It is a known fact, and it is a fact that we have the highest concentration of diversity in terms of genetic makeup that spans across the globe. And therefore, these kind of genomics and genomics germlines, pandemic surveillances, need to be researched by our experts with a clear mind that the idea is not only to give to make progress even only amongst ourselves, but it is in fact for the rest of the world. If the diaspora is crying now on the basis that it is oppressed, and it is where all of these negative and bad results and statistics that we have seen only are occurring to us, we have to turn things around. We have to turn all of that using the very same science, the very same power, with the very same resources that we find ourselves, at least from the African continent, for where I'm sitting, we've got enough. I mean, the energy sector that we have, Congo, where it is, has got the biggest energy, clean energy a generation that can not only feed the continent, in fact, it can be spilled over to Europe, things like that. Even in the healthcare, that is where we need to concentrate in order for us to proceed. So more research, more education, more research, more action in economy development, and all of that. That's what we need to do.
Thank you. Betty, are you ready on this one?
I didn't hear the question because I was looking at the question in the chat that I was trying to get some points for. But what can you just say it quickly? What it was?
Yeah, so what do you think our communities need to do in relation to...
Right. In Trinidad and Tobago, we need a more multidisciplinary approach that has started. We also need more data-driven, more data. We have a real challenge in collecting data and utilizing data. So research also, there's been a drive to increase research and have more evidence-based practice. So, and that was one of the things that really improved the results in the maternal and child health. The change was that Dr. Sergio Singh was more data-driven, more evidence-based, and more up-to-date. So I think that is basically what we need to do in order to improve things.
Thank you. Thomas?
I actually don't think that healthcare is going to resolve the health disparities problem. Healthcare is not the driver of the problem. The problem happens outside of the healthcare system. And I don't think that there are any pills or potions that we have or surgeries that we have to address racism. I think that what we need to do is develop more of a Pan-Africanist perspective that regardless of the countries that we're from, that the challenges we face result not from differences in our tribe or differences in our nationalities, they result from differences in our skin color. And we need to organize around that. We need to be communicating like this forum here today. We need to be communicating across the diaspora. We need to be learning from each other. And we need to place much less emphasis on our differences and much more emphasis on our similarities. And we need to be doing business with each other so that we can develop economically and utilize each other's talents and resources for the betterment of the overall African diaspora.
Thank you. And Jenny, last word to you.
Great. I think that here in the UK, we actually need more, or we need an organisation that actually challenges and advocates on behalf of Black communities, because we don't have a health organisation that does that. So any individual who wants to complain about the treatment they've received are often on their own. We should have, we should really have some kind of national organisation that can support and advocate. I think we also need to be doing much more research on, on the health experiences of Black communities. But I also think in relation to what Thomas has said, we need to have a society where there isn't inequality in terms of racism and discrimination. Now, I know, I haven't seen it in my lifetime, and I don't think my children will see that in their lifetime. So we have to do something in the interim, because we can't wait. I don't think people will stop, being kind of racist. I don't think that we will stop, having racism within our, within the NHS, within housing, within social services, within the criminal justice system. So while we can't wait for that to happen, we have to try and improve our experiences. And I think that may come through more activism and through more research and more lobbying.
William, can I add one more thing, if you don't mind?
Yeah, go ahead.
What I'd like to say is that another thing that I think we need to do, especially in forums like this, is that we need to define racism and not just use the term racism. Because when you talk to most people about racism, what they're thinking about is bigotry. Somebody has bad attitudes about somebody, and therefore they hold bad, negative beliefs. That is a form of racism, but quite frankly, I think it's the least important form of racism. You have structural racism. You have structures that were put in place, the way that we've organized society intentionally to benefit one group and not benefit other groups. Structural racism is devastating because it doesn't matter who is in control. If the system does what it does, it will by definition produce racially differential outcomes. But there's another form of racism, internalized racism. That is where people who are subject to these bigoted attitudes begin to believe their own inferiority. And if I can convince you that you are inferior, I don't have to create structures to hold you back. You will hold yourself back. So there are three forms of racism. There's structural racism, there's internalized racism, and there's bigotry. Bigotry is what most people talk about, but bigotry is the least important of them. And until we start engaging racism in a more sophisticated way and thinking about how do we counteract these various levels of racism, and we just talk about racism writ large as if it's a simple concept, and we let people to continue to operate under the assumption that we're talking about bigotry, we don't make progress.
Thank you, Thomas. That's a very powerful statement. And I think what this discussion has, in a way, showed, isn't it, that the global pandemic that we're suffering is that of structural, institutionalized racism. Our time is gone, unfortunately, but I think in a way it feels like we just started a conversation. So I really want to thank all our panelists, and I hope it's not what I would say is from our perspective, that it's not the end of a relationship, but actually maybe the beginning of an ongoing dialogue that we can continue as we try to work together to further work for the betterment of our people. So thank you so much to all of our panelists. Just hand over briefly now to Marge, who will brief announce.
Okay, thank you very much, William, and thank you to everyone. It's gone really quickly, and so I'm going to speak quickly because I just want to remind you of our next event. Our next event is the Black Pack Conversation, and that takes place on the 27th of May. I think we should have a slide coming up that just reminds us of that. If you can put that up, please, that would be great. Right, yeah. And our Black Pack Conversation is where we're going to be interviewing Dame Elizabeth Aninowu. Elizabeth was brought up in care until she was 9 years old. She was brought up by some nuns at the Nazareth House Convent in Birmingham. And she decided pretty early that she didn't want to be a nun. She wanted to be a nurse. She went on to actually be the lead person in terms of the lead specialist nurse in terms of sickle cell and thalassemia, something that affects an awful lot of Black and brown people. And as a result of that, she's done a lot of work. She's organized many of the clinics. She's been the one who's put the prototype together for what the sickle cell and thalassemia outreach should be in the NHS. She went on then to be an academic, and from that she's received a host of honorary degrees and so on, but not wishing to stop there. When she retired, she went on to actually spearhead the Mary Sickle, what is it now? Oh, someone remind me of the word. The actual Mary Sickle statue that was put outside St. Thomas's Hospital. So we're going to be interviewing Elizabeth Aninowu next month on the 27th. And I'm inviting you all to join us at that Black Pack event because it's going to be a fantastic time to hear her story and some of the things that has allowed her to carry on that journey with strength and determination over the years. So see you next month. But before you go, we do end up having what we call a little afterglow. So a few of us are going to stay on if you wish to stay on, but we have gone over our limited time. Thank you very, very much for attending. A couple of other questions that came up. I did put in the chat about the book, the reading that Jean did. A number of people are asking about where we get hold of that. It is a fantastic book. And it is in the chat, www.quickcrack. I saw an interesting spelling of quick crack earlier on. but it's just like the West Indian, crick crack, KRIKKRAK.com. But if you wish to stay on, please do that for a little bit of extra chat. It's been a fantastic time. Thank you so much to our speakers and to our wonderful audience. Thank you for coming. See you again next time around.
Thank you.
So we're going to stop recording now.
Wow, thank you. That was